I'm Dean Kereiakes, and I'm president of the Christ Hospital Heart and Vascular Institute in Cincinnati, Ohio. I'm professor of clinical medicine at The Ohio State University and deputy editor of JSCAI. I'm here today with Alexander Thomas, who's a fellow in cardiology at Yale University School of Medicine, and who is first author on a paper entitled Safety and Efficacy of the Supreme Biodegradable Polymer Sirolimus-Eluting Stent in patients with diabetes mellitus. This represents a pre-specified stratified subgroup analysis from the Pioneer 3 trial. Also joining us is Abbott, who's professor of medicine and director of the Interventional and Structural Cardiology Fellowship at Brown University School of Medicine. I want to welcome you, Alexander, and Dawn. And I'd like to start by asking Dr. Thomas to succinctly summarize this important subgroup analysis, the results of the study, and its clinical implications.
All right. So thank you again, Dr. Kereiakes, for the introduction, and thank you to SCAI for this opportunity to present today. So like Dr. Kereiakes said, I'll be presenting on the results of the diabetic cohort from the Pioneer 3 randomized controlled trial evaluating the safety and efficacy of the Supreme drug-eluting stent. I have no disclosures for this talk today. So as we all know, diabetics, especially those that require insulin, have been shown to have significantly worse ischemic outcomes following PCI. The Pioneer 3 trial recently established in a general PCI population that the Supreme drug-eluting stent was non-inferior to a standard of care DP Sirolimus-Eluting stent. The Supreme stent itself is a cobalt chromium stent that has a biodegradable polymer that's uniquely designed to degrade and elute its antiproliferative drug sirolimus over a 4 to 6 week time frame, which is on the order of 4 to 5 times faster than currently employed stents, and thereby allows for much earlier re-endothelialization and faster healing of the blood vessel. And as part of the Pioneer 3 study design, the analysis of the diabetic cohort was pre-specified, which I'll be presenting now. The Pioneer 3 study enrolled more than 1,600 patients with both acute and chronic coronary syndromes, of which 494, or approximately 30% of the original population, had diabetes and were included in this study. So the patients were randomized in a 2-to-1 fashion in favor of the Supreme drug-eluting stent, and that they were stratified by diabetes to preserve the randomization of the diabetic cohort for this study. So in the end, we ended up having 331 patients in the diabetic Supreme group and 163 in the DPES group. The key exclusions for the study were those who had presented with a STEMI, those who required unprotected left main intervention, those with an ejection fraction known to be less than 30%, and those presenting with cardiogenic shock. The primary endpoint was target lesion failure at 12 months, as typically defined, and the secondary endpoints included the components of the primary endpoint, MACE, and its components, stent thrombosis and bleeding. Here we can see the baseline characteristics for the diabetic cohort. Clinically, among the whole population, 33% were on insulin, 35% presented with acute coronary syndrome, either unstable angina or an NSTEMI. The clinical variables were very well matched between both groups, both with but with slightly more stable angina that we saw in the comparison group compared to the Supreme group. Angiographically, among the whole population of diabetics, 1/3 of the patients had multivessel disease, 2/3 had complex lesions, and nearly 40% of the lesions were classified as being either moderate or severely calcified. We also observed a pretty high rate of radial access at 76% radial access use for the procedures, and overall relatively low utilization of both invasive imaging and physiologic testing. The angiographic variables were again well matched between the groups. However, within the Supreme group, there were more complex lesions and slightly fewer cases of multivessel PCI compared to the control. So here we can see the results of our primary outcome, target lesion failure at 1 year. The event rates were 6.1% within the Supreme group and 3.7% within the control group. The difference between these two were non-significant, and the hazard ratio was 1.65. Here are the components of our primary endpoint, target lesion failure. None of these three did meet the differences between which did not meet any clinical significance or any statistical significance, though numerically the Supreme group had a lower rate of cardiac death and a higher rate of clinically driven target lesion revascularization. The target vessel MI numerically was nearly identical. So in the additional secondary outcomes, which included target vessel failure, MACE, stent thrombosis, and bleeding, we saw that there were no major differences between either of the groups, either the Supreme or the DPES group. So now, putting the results of the Supreme Stent into a larger context, here are the rates of target lesion failure for many of the recent stent trials, where I've listed both the target lesion failure rate for the total populations, as well as for the diabetic-only subgroup analyses, which are represented here in bold. We can see that among the general population, target lesion failure rates are typically ranging on the order of 4 to 7% at 1 year. Then among the diabetic subgroup analyses, we see rates of target lesion failure increase to the 7 to 10% range. So now when we include the Supreme Stent's performance among diabetics, we see that the target lesion failure rate is 6.1% and actually much lower than seen in other diabetic sub-studies. And it is even on par with some of the rates that we saw in some of the general population. So overall, in conclusion, we found that the Supreme drug-eluting stent demonstrated both safety and efficacy at 1 year within a diabetic population compared to the standard of care durable polymer Sirolimus-Eluting stent, and that when compared to other recent trials of drug-eluting stents in diabetics, the Supreme stent demonstrated overall a lower rate of target lesion failure. And currently, the evaluation of longer-term outcomes are ongoing with plans to follow this population out to 5 years. And I just want to say thank you to the co-authors, especially Dr. Lansky, who's been a great mentor through all of this.
Well done, Alex. I think that was an excellent summary of a prospective and stratified, which means you created a randomized trial within a trial. This is always a much more legitimate and credible subgroup analysis. I see we also have Michael Farkouh joining us, which I am thrilled. And I didn't get a chance to introduce Michael initially, but he's chair of the Peter Monk Center of Excellence in Multinational Clinical Trials and vice chair of research in the Department of Medicine at the University of Toronto, and an expert. Michael was also intimately involved in the FREEDOM trial of diabetic patients. So Michael, it's great to have you here with us. You've just seen this presentation of a
Yes, very, very impressive. Thank you very much, Alex, for a great presentation.
Thank you.
What are your comments in seeing these data, Michael?
Well, I think that it shows that we have a lot of room for improvement in the outcomes of patients with diabetes undergoing percutaneous intervention with stents, and I think this is an advance. I think that compared to the everolimus stent, there's some differences, but not statistically significant for the most part. And that compared to historical controls, we see some promising findings that we can even reduce target vessel failure to a greater extent. So I think there's room to move. I do think that contrary to what many people believe, those of us in clinical cardiology, that everyone should have bypass surgery, we still have the majority of our patients with diabetes undergoing PCI, and we need to find ways to have the best possible outcomes. And I think this is a step forward.
In that context, Michael, what are the components of diabetics? What are the reasons why diabetics have more events, why they have greater restenosis, et cetera?
Yeah, it's really a number of pleiotropic effects. It's the lipid interaction and the fact that patients have low HDL, and they also have interaction with LDL, even though LDL levels tend not to be as high in diabetic patients as they are in other patients with atherosclerotic vascular disease. The whole interaction and the importance of lowering LDL to far lower than 70 milligrams per deciliter has been proven. The other thing is there's a prothrombotic milieu. Patients are more likely to clot. And then the final thing is inflammation that's seen with diabetes that we think is playing a major role and has been one of the major components to worsening outcomes.
So, Dawn, what are your thoughts in looking at these data, and are you cautious about the hazard ratios that we see with TLF and clinically driven TLR?
Yeah, absolutely. As pointed out, the diabetic subset is higher risk. And I think as an interventional operator, we need to really interrogate the vessels a little closer. They often have negative remodeling. We might have smaller diameter stents. So it's a little disappointing to see that the use of intracoronary imaging during these procedures is so low, because I think we could achieve better outcomes if we were appropriately sizing. It's been really difficult to demonstrate superiority of one type of stent, say a durable polymer drug-eluting stent versus a bioabsorbable polymer drug-eluting stent among all patients, but in addition, in the subset of those with diabetes. And Dr. Chirag Bhavishi, when he was at Brown with me, we did a meta-analysis, had over 5,000 patients, all contemporary drug-eluting stents, and we could not find a difference between bioabsorbable polymer and durable polymer in any safety or efficacy endpoints. So, I think it's difficult. It's a little concerning that the absolute rates are higher in the BUMA stent, but I think, again, we have to be cautious because it's statistically not significant, and maybe longer term follow-up will demonstrate a greater difference. But we know from the biology of the stent that it has greater late loss than some of the durable polymer stents, and that may be translating here in these events.
And the TLR, at least.
Yes. Yeah.
Alex, there wasn't a section on specific limitations. Tell me what you think the real limitations of this analysis are.
Yeah, so I think it's sort of what Dr. Abbott touched on a bit was some of the higher hazard ratios. And I think that a lot of them are largely driven from the small sample size in the control arm, in the durable polymer everolimus stent arm, where there's only 163 patients. I think that is probably one of the definite limitations to this study, because we are seeing these sort of high hazard ratios, but they don't meet clinical significance. I think that one sort of telling point in that is the fact that we see that the actual rate of target lesion failure in the diabetic cohort is actually lower than the rate of target lesion failure in the overall cohort from the original study, which is 5.1% compared to 3.7% that we're seeing in the diabetics. So I think that does limit our analysis here for sure.
Well, I think you're absolutely right. When you drill down into the data and find 0.7% clinically driven TLR in the durable polymer EES for 1 in 163, it's got to be play a chance. And the comparator looked great, but it's underpowered. So you have a hazard ratio that approaches 4 with p-value that's non-significant. So I think it's difficult. Michael, do you think that with these data, this is stratified, they created a randomized trial within a trial. I've been involved in the diabetic labeling, if you will, of multiple other stents, including the Absorb BVS, Synergy, and Xience. Do you think this is adequate to obtain a labeled indication, or do you think this is one piece of the puzzle?
Yeah, I'm not a regulatory person per se, Dean, but I do believe that it definitely confirms that the event rates are lower enough that I think it could be considered, but may need confirmatory data. I think it likely will need further confirmation, given the analysis. And the question, Dean, comes up, do we do trials exclusively in diabetic patients to have adequately powered trials, as opposed to it always being a subgroup within a larger randomized trial? And here you had some high-risk patients, about a third of the patients on insulin. Those are a different cohort as well. So maybe having a more homogeneous population may help as well, who are on oral agents only.
Yeah. Or a 1-to-1 randomization would have given you 250 almost in each group. as opposed.
Yes, you lose power when you have disproportionate randomization, as you point out. It's a great point. And so that's the other limitation here, is that you would have perhaps greater power with a one-to-one randomization.
Yeah. You also saw some differences, which you tend not to in true large-scale randomized trials, differences in baseline characteristics that may or may not contribute to these differences because of the asymmetric randomization.
Yes.
Any other comments that you would make on that, on the limitations of this analysis?
Again, this is a trial that was designed for clinical endpoints, which is generally what we rely on. But again, when we're looking at these small event rates, trying to determine a mechanism of one stent versus another in terms of why a certain event happens is, you can't use this data for that. So again, I think all the things you pointed out, just by chance, the randomization, the lesion complexity may have been higher in the BUMA arm. And again, that's just play of chance. So those are just limitations you can't overcome.
Excellent. The fact that it's more comer and not all comer, this is not surprising. I mean, any trial done predominantly in the US, is not going to be an all comers trial. I don't think we've seen that in a long time. I don't know that we're going to see it, frankly, except in post-market studies. So this is not all that surprising to me and doesn't make it any less useful, to be honest. The concepts, and Alex Thomas, if you could maybe give us some insights, the things behind this device that makes the proposal hypothesis that it's pro-healing could include what are the evidence for that, the structural components, et cetera, like the PBMA base coat, the synchronicity, if you will, of polymer resorption and drug delivery, and what kind of preclinical work was done to suggest that this device might be safe in the long run.
Yeah, so I think that the fact that the stent allows for very early degradation and early release of its drug allows the vessel to heal quicker, and has shown evidence that there is early reendothelialization, and then with that you get some of the vessel physiology back, and also shorter duration of inflammation, which is a very chronic issue in diabetics. They have much larger inflammatory responses, and sort of chronic inflammation, which can lead to faster restenosis and more clinical events. And I think that that's really that earlier reendothelialization and the decrease in overall inflammation time is really one of the benefits of the stent that you would see.
Dawn, any comments on that?
Yeah, no, I think it's always a trade-off. You've got the restenosis potential and the healing potential, and it's just really trying to find the balance. And like every drug-eluting stent platform is trying to seek this balance. And again, I think at the end of the day, it's really hard to differentiate them when it comes to looking at clinical events, because some of these responses are going to be so subtle. And again, it takes a lot of late loss to make a clinical event. And not everybody with incomplete endothelialization will have a stent thrombosis. So things don't translate one-to-one with the biology is all I'm saying.
Yeah, no, I agree. And I would caution it may be too early to, some of the preclinical findings that Raiden Vermani group had for this device had to do with Evans blue staining and albumin permeability, the correlation with late neoatherosclerosis. So if there's going to be less permeability, less neoatherosclerosis in follow-up, we wouldn't see it here at this point.
That's right.
That may be a differential. And, these things happen. I tried to write up a platinum trial, originally because of differences at 2 years that looked to be in favor of one device versus the other. And Greg Stone said, let's watch it another year. It came back. So what we're seeing right here, there may be a catch-up phase, or there may be protection in later follow-up if neoatherosclerosis is indeed diminished with this device. So
this is a great point, Dean, that the longer term follow-up is very critical here, and as pointed out by Alex.
excellent. Alex, any closing comments that you would say? I mean, this or Dawn, Michael?
Yeah, I think overall, from this study, I think the rates, like Dr. Farkouh had said earlier, the rates of target lesion failure that we're seeing in this new stent, even though it was higher in number than the comparator, are very encouraging, and overall are much lower than we've seen in other clinical trials.
Yeah, I'd just like to congratulate you on a very well done trial.
Agreed, and very well presented, Alex. And I think that, again, I'll make the plea that we study diabetes patients in their own well-powered analyses, I think is the future, because we're seeing a high burden of diabetes. And again, many patients are appropriately selected to have PCI, and we're going to face this problem in the future. So we need the best platforms possible and the longest term follow-up.
I think Michael's comments are not prescient. They're become obvious with the growing burden of diabetes. But you're absolutely right. This is not becoming less of a problem in our society. It's becoming more of a problem in every industrialized nation. So, and younger people are being involved. So completely agree. Alex, excellent job. I want to thank Dawn, Alex, Michael, for participating in this, and JSCAI for giving us the opportunity to review this important paper and subgroup analysis. Thank you very much.